Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Archana Bindra. Dr. Archana Bindra is board certified in endocrinology and internal medicine. Dr. Bindra attended medical school at Seth G. S. Medical College, King Edward Memorial Hospital, University of Bombay, Mumbai, India. Dr. Bindra completed her residency at the Department of Internal Medicine, Los Angeles County, and the University of Southern California. Her fellowship was completed at Cedars-Sinai Medical Center, UCLA. Dr. Bindra currently practices medicine in the field of endocrinology.
I'm an endocrinologist here in Fremont, right across the street, and do a lot of work with pumps for quite a few years. I did most of my training, fellowship training at Cedars-Sinai, where I think I saw my first pump. So if it was exciting then, it's still exciting, and hopefully it can continue to be exciting. So we're just going to talk very basics about insulin pump therapy, and I'll share what I know. So I don't know if any of you recognize these people. This is Banting and Best. Without them, you wouldn't have insulin. They treated their little dog with the pancreas that was inserted into him from another animal, which had, of course, insulin, and that's how he was saved, and his blood sugars were brought down. Diabetes has evolved over the years. We used to figure out when somebody had high blood sugars with a urine testing in 1776. We later on in the 1900s decided to do urine test strips. I think those are a lot more better than actually tasting urine. Then they found out insulin in 1921. They came up with blood glucose meters in 1977. And they decided to come out with a pump in 1978. And then, of course, later on, we came out with glucose sensors, and they got more sophisticated, and now everything talks to each other, and so we have something like an artificial pancreas. So this is how the first pump looked in the 1970s, and I don't know, but you guys are sitting here right now. It hasn't changed very much since then. We still hand it out with a big backpack, and that's exactly how it looks. So I'm not quite sure if you really want to sign up for something like this. These are how they look nowadays. They've evolved quite a bit. They're as tiny as a little beeper. And this is pretty much how they get inserted into your belly with just this little spaghetti tubing. And it's all plastic that goes in, so there's no actual needle. So why are we so interested in getting a pump? I mean, we have oral medications, we have insulin that you could inject a few times a day. What would be driving us to actually get a pump? Well, they have noticed that as you have an elevated hemoglobin A1C, so let's backtrack a little bit. A hemoglobin A1C is an average of your blood sugars for the last 3 months. It comes in the form of a percentage, and usually we'd like it to be less than 6.5. So the higher it gets, the more the complications you have. As you can see that if you're in the lower part, you start noticing initially you have what we call microalbuminuria, mild retinopathy, neuropathy. These are all microvascular complications of diabetes. As it progresses, your risks of getting other conditions increases as well. You start having more of retinal involvement, teeth involvement, gastroparesis, depression, etc. And as the risk goes on increasing as the A1C rises, then you start having the bigger problems, as in heart attacks, strokes, blindness, amputation, may go on dialysis, etc. So as your hemoglobin A1C rises, your risk of all these conditions also rise. With the insulin pump, you're actually able to bring down this risk. And you've noticed that the use of people using the pump over the years actually has improved markedly. I can't see properly, but I think in the 1990s it was 6,600, and now in 2002 it's over 200,000 people. So there's a huge difference of people using the pumps. There was a trial that was conducted in the late 1990s that looked at intensive treatment of diabetes and whether if you treat people with an intensive regimen, does it actually decrease your risk of developing eye disease, kidney disease, and nerve damage, as in retinopathy, nephropathy, and neuropathy. And there is a significant reduction, as mentioned here, as 63%, 54%, and 60%. And therefore, the only way you actually get this intensive treatment is either by injecting 4 times a day or by going on an insulin pump, which actually mimics your physiologic release of insulin in the body. So there's an advantage of CSII, which is continuous subcutaneous insulin infusions. So the goal of insulin therapy is essentially to mimic your normal pancreatic function. So as you notice, if once you eat a meal, this is breakfast, lunch, supper, and a bedtime, HS is bedtime. So once you're eating a meal, you notice that you have your spikes of blood glucose, and then supposedly at night, you're supposed to be all flat. Your insulin rises proportionately at the same time in a person who does not have diabetes and who has normal insulin functioning from the pancreas. And that is actually the goal of your insulin pump. Your insulin pump wants to mimic your pancreas in order to bring down your blood glucose in the way that your normal pancreas would. So when we talk of this basal bolus regimen, we're talking of 2 different types of insulins. We're talking of long-acting insulin and a short-acting insulin. The long-acting insulin is what we call glargine, which many of you, prior to going on a pump, or many of you might already be on. This is a long-acting insulin. It basically works all day long in a flat mode for 24 hours, and it gives you what we call a basal amount of insulin. These big humps are when you eat a meal. This is a very short-acting insulin, and it works for a couple hours. You inject it before you take breakfast, lunch, and supper or dinner, and it works only for those 2 or 3 hours of your meal in order to bring down the blood glucose. And we call this regimen a basal and a bolus regimen. And you could do that with glargine. Nowadays, there's other insulins that are long-acting as well. This slide was probably made when there was only glargine available, or Lantus, but now you have so many different other ones. And Lispro is a short-acting. There are other ones available as well. So for continuous subcutaneous insulin infusions, they follow the same pattern. You're trying to mimic this in general in your body. So who goes on an insulin pump? Who would be a very good pump candidate? Somebody who has bad glucose control, yes. Or you could be on 4 shots a day. You have a high hemoglobin A1C, and you feel that you would get better control with it. Somebody who has hypoglycemia unawareness, which essentially is that your blood sugars go down into the 20s, 30s, 40s, and you do not recognize it at all. We have several patients who've had diabetes for long periods of time, and as you have long periods of time of diabetes, you end up having a lot of nerve damage. The body doesn't recognize that your blood sugars are actually dropping. And it's very dangerous for these kind of patients to drive, or for the risk of having accidents. If you keep having hypoglycemia again and again, that's another reason to think about going on a pump. Because a lot of times when you've had diabetes for a long period of time, it's very difficult to keep it as a stable dose and to achieve stable control. Whereas if you go on a pump, it's a lot easier, and I'll explain to you why later. The dawn phenomenon. There's a surge of hormones that come out at 4 o'clock in the morning. We always wonder that if I went to bed with a 90, how do I wake up with a 180 or a 200? Well, the liver makes glucose overnight, because if it didn't, we would all be dead in the morning. So the liver has to make glucose. And of course, there's a surge of other hormones that come into play at about 4 o'clock. And they get you up and get you out of bed and get you rolling and get your blood sugars higher. And we call that the dawn phenomenon. It occurs at dawn. Then when you're thinking about getting pregnant, then preconception areas and pregnancy is a time to also go on an insulin pump to have better outcomes in pregnancy. Gastroparesis. Gastroparesis is a little bit like hypoglycemia unawareness. What happens in gastroparesis is that, again, you have nerve damage. You don't have the transit of food is very, very slow. People have a tendency to develop nausea and vomiting. Post-renal transplants, you go have a kidney transplant. That's a time to actually keep your kidneys in good shape. And a lot of these patients are on steroids and other immunosuppressive agents, which makes it very difficult to control their blood sugars. And at that time, a pump is a good idea. There are probably a few other cases as well that you could think of, but these are the most common ones that we come across. What are the advantages of going on a pump? You definitely have improved blood glucose control. It's a precise dosage delivery system. And what does that mean? When you inject 30 or 40 units of a long-acting insulin, or maybe 10 units of a short-acting insulin, that the amount of absorption or the timing of that absorption is very variable. You could have, in a long-acting insulin, it's supposed to be working for 24 hours, and we're assuming that we're going to be getting a steady dose of insulin for 24 hours. However, a lot of times you may get 4 units in 1 hour, you may get nothing in the next 3 hours, you may get 10 units in the 4th hour. It all just depends. Whereas in a case like this, you actually would get so many units per hour because that's how it's programmed. So the amount that you would be getting would be a very precise amount. So again, improved control for preconception, management of dawn phenomenon. It gives you a lot of flexibility in lifestyle. You see a lot of people who travel a lot, who work at night, they have graveyard shifts, or their nurses like it a lot. People who work in a lot of shifts, who keep having changes in their lifestyle patterns. In general, it gives you a lot of flexibility because you can manipulate that little box as much as you can in order to give you the lifestyle that you need to get. It gives you a lot of control during exercise. A lot of you have noticed that blood sugars drop. Sometimes blood sugars rise after exercise, and that can be, of course, taken care of. It also helps with gastroparesis management. So who doesn't get this? I do believe that if you cannot operate your remote control for your TV, this probably is going to be a hard tool to work with. But most people can, and most people, if they can operate a smartphone, they can definitely operate a pump. And in fact, it's probably easier. And if you're able to check your blood sugars 3 to 4 times a day, then that would be one definite indication that you would be able to do it. If you carb count on a regular basis for your basal bolus regimen, in order to calculate a bolus, you need to know how many carbohydrates you're eating, and you would have to count the carbohydrates. So that would be an indication. Initially, document activities of daily living. I mean, if you can actually take care of yourself, you're able to carry out these few things during the day, that would be fine. And then you always want to follow up with your doctor. You want to come for your follow-up appointments. It involves a little bit of a regimentative lifestyle. You can't sort of say, oh, this machine is kind of going to take care of me. It's going to do everything for me, and I don't need to worry about it. There was a study that was performed where it was people using the pump versus people on injections. And it was 58 patients, and it was done for 3 years. These were all patients with type 1 diabetes. And what you entirely notice is that in all the blues are all the pumps, and the red, this orange, is all the multiple daily injections. That's what MDI is. And you could notice that the hemoglobin A1C, which is the percentage that we mentioned earlier, is lower in every one of these aspects. It's 7.7, 8.2 versus 9.2, 8.4 versus 10. Pumps, in general, give you less variability of blood sugars, as we mentioned, because you're getting a certain amount of insulin per hour. So if you notice, the excursions are only minimal. This person goes anywhere from 100 to 200, whereas this person goes from 50 all the way to 400. And so you can see how many variabilities are just in one day as compared to this person's. And all these little dots that you're noticing are the finger sticks that were done in order to calculate that. So insulin therapy in general can cause low blood sugars, which is also a risk. And with pump therapy, you're minimizing your low blood sugars. Prior to pump therapy, it's 138, and it drops all the way down to 22, 26, and so forth. In general, your health status improves with pump therapy. 82% were improved, and about 16% had no change. So what does it do for type 2? Initially, pumps were mostly for type 1. It was mostly for children. That's how it evolved and when it first started out with. But now we use it a lot in type 2 diabetes. And what it does for type 2 diabetics is it reduces the glucose toxicity. So once your blood sugars reach the 200-300 levels, unless they're brought down, and the only way to bring them down at that point is usually insulin, there is an element of glucose toxicity whereby glucose is not being able to taken up by the muscle, and therefore none of the oral medications would work at that point. It also decreases insulin resistance. What is insulin resistance? So the easiest example possibly is that if in a non-diabetic you require a unit of insulin, it would bring down the glucose by 50. For a diabetic, you would need maybe 10 units to do the same job. So there, the insulin is there, but the insulin doesn't work as well. So the insulin just doesn't help the glucose get taken up by the muscle. And that's your definition of insulin resistance. Most of type 2 is caused by obesity, and therefore you have insulin resistance. It restores your sensitivity to oral agents. I'm not saying that everybody who goes on a pump is one day finally going to go back on an oral agent, but it does help your blood sugars to be lowered, and thereby maybe if you are concomitantly on metformin or some other oral drug, it might work better. But it definitely reduces your total daily insulin needs. A lot of patients who take 200 units of insulin a day or 100 units of insulin a day, we notice that their total daily needs decrease by about 40% on an average. So, which is a big drop, because that actually decreases your weight. It also gives you a little bit more satisfaction, especially when you start seeing good blood sugar control. So there is challenges associated with pump therapy. It definitely is a learning curve. You may have a chance of developing DK, which is diabetic ketoacidosis. We'll talk about that later. Sometimes people gain weight. The weight gain usually comes from the fact that a lot of people just, oh, I can eat this and give yourself a little bit of that. Or I can eat that and give yourself a little bit more. And we've had a few patients who do that a lot. And then I've had actually a couple of them who said, I don't think I want this anymore because that's what I've been doing all along. But I wouldn't think that that's a good reason to get rid of it, though. Frequent monitoring, yes. Once you put that thing on, that thing doesn't do everything for you. You still have to check your blood sugars. The pump has a certain amount of information, but it has to be fed some information as well. It has site of infections, very, very minimal, as long as you change the site every few days. I mean, we've almost never seen a site infection. Inconvenience in wearing it. A lot of people complain, how am I going to sleep with this? I roll around a lot, it falls off, or et cetera, et cetera. There are ways to go about that as well. You definitely need to have a lot of education along with it, but I think in diabetes in general, you need to have a lot of education. Follow-up is required, as like any other medical condition. And of course, there might be a cost issue that's involved. So what is this thing? How does it work? So an insulin pump, as we mentioned before, looks like a beeper. It is a battery-operated device, and it's filled with insulin in a reservoir. The reservoir is in this area here, and you fill it in a certain way, though you'll be taught. Of course, it has a little computer chip, and it's fed with some data, and it's been programmed, usually by your physician, and you wear it all day long, 24 hours a day, and it delivers only one kind of insulin. So you won't have the long-acting insulin at all. You only have the short-acting insulin. So essentially, it gets inserted into the skin. It doesn't go deep down. It's not going miles and miles down. It's a little spaghetti tubing, as you can see here, that sort of just goes right underneath the skin, and it's delivering the insulin. The dosage is all calculated into this little computer that's right in here, And when you feed the data, such as the carbohydrates you've eaten, the blood sugar that you have, which now actually can be transmitted directly from your meter directly into the pump, so that those errors don't exist. That actually helps this machine to realize how much it needs to tell you to inject, and you press a little button and you get your dose. Essentially what it's doing is what the body does naturally. It's giving you a basal insulin. That means it's giving you something per hour continuously. And it's also giving you something to cover each meal, which is in the form of bolus that you're going to actually give yourself the bolus. It is a microdrop insulin delivery system. It's flexible, and you can correct your high blood glucose levels. It has a lot of buttons and stuff. It might look very intimidating at first, but I'm not a very tech-savvy person. I'm not very good at things, I can tell you, but a pump is something that's very easy to learn. And there are certain pumps that might be easier to learn than other pumps. And some people prefer a certain type of pump as compared to another pump. Some of them communicate with these certain blood glucose meters, some don't. Some of them have continuous glucose monitoring systems with them. Some of them can tell you how much insulin is on board. Some of them you could suspend your pump for a while. You have all kinds of different features that you could play with. But they do rely on input from you as patients in order to calculate the dose. So it's not going to happen automatically. Can't sit there and say, oh, it's going to just automatically take care of my large pizza that I've eaten. It doesn't work. There are different kinds of pumps available. And then, of course, you need a whole bunch of things with it, which is all supplied by the company. So you don't have to go to a shop and worry about getting all these different things. You get infusion sets, you get reservoirs, of course, insulin. How do you prep your skin? The alcohol wipes. How do you put the insulin into the reservoir? The pump batteries. How do you insert it into your skin? The inserter. And, of course, everything, all the instructions with it. So we have something called continuous glucose monitoring. And what exactly is that? That is something by which, at one time, we just had the pump, and it gets inserted, and you have your glucometer. But now you have a sensor that actually detects your blood glucose on a continuous basis and tells your pump what to do. And it prevents you from, of course, having low blood sugars. It tells you when you're high. It minimizes your fluctuations and all these kind of things. So there are actually three parts to all of these. There's a sensor, there's a transmitter, and there's a receiver. So the sensor is this. It's this little thing. And then you have the transmitter. And then you have the receiver. And that's your pump or the monitor by which you're going to actually do something about it. So if you take a look at this, they call it the artificial pancreas device system, because that's your little pump, that's your little glucose monitor, and it's talking to this little computerized thing to tell your pump what to do, and that is what it ends up doing. So you have a continuous glucose sensor, you have the pump, and they all talk to each other. And that's how your closed loop system is. I think I am done.